Assalamu alaikum. Welcome to KQH GAT Club. We are happy to be here to present our two cases. It's a very interesting case. I need to thank Dr. Osman Harbi. It is officially, originally this is his case, but we share the management and hopefully a good plan for her. And the other case, actually, it was also Dr. Walid Al-Hamoudi case. We will try to be interactive as usual. The two presenters would like to thank our fellows, Dr. Abdullah, he's well-known F2, and Dr. Jaweed, our new hepatology fellow, for presenting the two cases. The first case, it is easy to diagnose and difficult to manage, while the other one would be difficult to diagnose but easy to manage, and then we will know the difference.
Bismillah ar-Rahman ar-Rahim. Aglam Tagdi, second year GI fellow. I'm really glad to have the opportunity to share with you the challenge that we met during management of this patient. Our patient is a 40 years old lady who presented to our hospital with 6 months history of the gastric pain, vomiting, and weight loss. The abdominal pain was colicky in nature that got worse after taking food and relieved partially by vomiting. The vomiters had food content. She gave history of anorexia and weight loss around 15 kg over the last 6 months prior to presentation. There was no history of hematemesis, melena, fever, or change in bowel motion. Her past medical history is significant for a history of hypothyroidism and history of colonic polyps. Past surgical history, she had history of scalp lump removed in another hospital and vulvar lump, which was reported as the reports she got as epidermal inclusion cyst. She has a family history of her father being died at an age of, before age of 50 with possible history of colorectal cancer. She's divorced. She has a history of depressive symptoms and follow-up in psychiatric clinic. She's been prescribed some antidepressant, but she was off during this encounter. On physical examination, vitally she was stable, she was afebrile. Her weight was 46 with a BMI of 18. Generally, she looks in mild pain. She was pale but not jaundiced and looked underweight. Her chest, cardiovascular, and abdominal examination was remarkable. There was no skin or musculoskeletal changes. Overall, she was a thin, pale lady in mild pain with normal vitals and non-contributing remaining of exam. So, what would you do next for this lady?
Any thought, any idea? Now, this is a history. Told to have some kind of polyps. Her father died at the age of 50, mainly epigastric pain, vomiting, with significant weight loss. We will come, but from the history examination, anything differential? No jaundice.
No jaundice. Six months.
Can you start with the more junior?
6 months.
6
history.
months, yes. Peptic ulcer, okay. Okay. Yes. Outlet obstruction, Prof. Due to what? Anything? Severe mesenteric artery syndrome, pancreatitis. Dr. Abid, any thought? So.
With the history examination, it's difficult to have a specific diagnosis.
Yes. Okay. The junior actually from the juniors around are from our KQH, so difficult to. I know senior here, Dr. Afzar, and anything you want to. Any thought? So, sorry. Familiar bulbosis. But how to explain this her symptom and I think good thought because the family history of colon cancer and some polyp. Her age around 45 with this symptom. Any thought for why this upper GI symptom? Okay. So we'll
Proceed. So we'll start with the initial labs. She had a CBC, was showing hypochromic microcytic anemia and with high RDW, giving a picture of iron deficiency anemia most likely. This is her UNE with some range of just lowish sodium. She was not in acute kidney injury. This is her LFT with a low albumin, if I would indicate. Otherwise, her LFT was essentially normal. So, next, what would you think to do?
can you proceed next, at least to the abdominal X-ray
This is the imaging, hopefully, I don't know if it's clear, but this is the abdominal X-ray. Almost there is no air fluid levels, there is no air under the diaphragm to indicate the possibility of
So what is
traction or-
next? This is her basic investigation. Apart from mild anemia, there was nothing, and hyperchromic myocytic anemia
with low albumin as
was
well.
low albumin, and this is no. Also, she looks obstructed, but no air under no air fluid levels, and no dilatation of the small bowel. You will proceed with what?
You proceed with endoscopy, I mean.
Endoscopy, CT, celiac profile. Celiac profile done, but
I believe it wasn't done because essentially we had even, if would allow me to go for an imaging from outside that she did. Just to show you the imaging, I will need someone to comment on it. This is CT from outside. This is a coronary
from
section.
the senior, yani this you will start with image first or endoscopy? She has
Endoscopy,
obstructed.
but I mean,
with-
this already have an image already had, which is a huge stomach there, so it is.
Ah, he
Anything
put the
else?
image. Okay, this is from outside actually. She
Yeah.
can't answer.
I think it's gastroparesis.
Usually in this case, you'll start with gastro or image?
CT.
Both is right, but I will go with the endoscopy usually in patient who's weight loss and something. But you should be careful about this patient that they should be in clear fluid initially and then be fasting and then you go ahead. You don't let them eat and fast overnight. That's not enough. Sometimes you may end it with like they vomited during the procedures. Under sedation, you'll be in trouble.
Yes, Abid, this is a comment that scenario, symptom, obstructive symptom, and scoping them, a lot of retained material in the stomach, and they vomit, aspirate. So you would like to start usually with image, or like Dr. Khalid, overnight, or 2 to 3 days long fasting and. Actually, she, yes. So she came with her image from outside, then we proceed for up.
Any comment? Yeah, I mean, I need a comment on the findings. So she has a dilated stomach. What else? I mean, there's clearly, yeah.
There's something there, yeah.
Yeah.
This is the one. It's beyond even a thick wall. There is like a mass-like lesion, which is being more clear going to the back. So
Anything else apart from this?
what should come in our mind? I mean, like seeing such a lesion, what would come in our mind? I mean, this will limit our differential diagnosis.
Huge stomach and this mass. That's all.
Secondary to what? Peptic ulcer disease, for example. I mean, why should it have such a mass like? It's outside the stomach. Yeah, it's clear, but it's in the way. If I would guide you, just
You don't know whether it is a mass or is a bezoar because of the food or something like that. You don't know what's going on. It's outside the stomach, this one?
yeah.
Yes, because
Talking
the
about something
wall,
outside.
Yeah, it's outside.
you can see the wall of the stomach clearly.
Yeah, just
Could
to
be
give a
lymph
hint
node,
as well, it is in the
tumors,
small bowel, in the
compressed.
duodenum. This is something related to the duodenum. If you will follow it.
What could be differential this duodenal?
So intramural or extramural,
Extramural.
lymph nodes, masses, tumors, all of these are differential diagnoses.
Okay.
Okay. So what would you do next? What I believe everyone asked for, whether endoscopy or CT. We had the CT. So the next will be our. Okay, so endoscopy. This is esophagus, and this is the stomach. Before I go to the duodenum. Is it clear? I hope. It's clear here, but here.
So I think Nawaf, he just came. Yeah. Tell us. Huh. Nodularity. Diffuse, okay. Okay.
Okay, this is the first part. This is
This is the
duodenal
first
bulb.
part, nothing.
And this is the second part.
Second part.
And proceeding further to the third part of the duodenum and fourth part, we're having these lesions getting larger and larger to an extent almost obstructing.
Here, no more lumen. When I entered, there was no more lumen. And
These type of things, you see it here. فاميليا بالوسط يا جماعة فاميليا بالوسط. This looks like a polyps, really. This like polyps, and you see it. Most of the time, you see this with the patient with the FAB, and will be dangerous if she had the FAB and this age. I mean.
Her father died of cancer. TB, diffuse like this and this. We have a polyps, multiple actually, and as Nawaf mentioned, numerous, uncountable in the stomach with all variable, but in the range of 5 millimeter, and with this duodenal polyp. So we proceed with.
Yeah, as endoscopist, we proceed as well with
colonoscopy.
endoscopy to further delineate the extent of these lesions. And you can see distal to these lesions, almost to the proximal jejunum. It's normal. There was like one jejunal lesion like this in the proximal jejunum, beyond which until the end of the enteroscopy, it was normal.
So it was bush enteroscopy. We was able to manage to go beyond this, but multiple variable. Some of them are really very large, reaching. We will come to that.
So you
This
think
way,
hematomas?
what do you think, with this numerous polyp, her history of father, and so it is familial?
Is it the age for duodenal involvement, for upper and duodenal involvement?
They can.
She's 40, 39, 40.
45, 40.
Sure.
But she's 45, her colon
Okay.
is still there. We didn't investigate. So, attenuated. But here, this is, you see, numbers here.
So, where do you want to go now?
Colonoscopy.
Colonoscopy? Sure.
Go.
This is colonoscopy. A lot of polyps. So the colon is there, and a lot of polyps are there. Some of them,
Some huge.
they are, as been reported, innumerable. I mean, you cannot enumerate them, and some of them extending more than 1 centimeter. So we took part of those lesions in the upper GI tract as well down, and these are the findings. So the stomach polyps are reported as sphincter gland polyps. Duodenum and jejunum polyps are reported as tubular adenoma, and some of them with tubulovillous texture as well. Colon polyps are tubulovillous adenoma with occasional severe dysplastic glands with no evidence of stalk or stromal invasion. So, do you think?
Take her colon out.
Take her colon out. As diagnosis of any risk, any workup you want to do before you call the surgeon?
You have the.
So it is a FAB or variant of FAB or
Whatever it is, I mean, I think if you have the what do they call it, the analysis,
Genes.
screening. There is a DNA or whatever there. They can the gene. If you can do the gene, that's good. But if you don't have it, this is a classical of FAB.
FAB. Okay.
Fab. So you would just call the surgeon, take her colon out.
I mean,
and that's it.
you need to look at her retina. You have to look at
Why? Why should
something,
we look
have
at her
to
retina?
You have to look to the
Can we ask the
abdomen
fellow?
fold.
Nawaf. Okay. And what else? What other organ you need to look for? Brain, skin, skull, stomas, and thyroid, adrenal.
Looking for what, Noah? Okay. So just to complete the story, we're intentionally hiding some information that we collected after. We elected to present it as we got the patient. Later on, we got more information from her previous presentation to other hospital. So her father diagnosed to have FAB at an age of 34. He underwent colectomy, complicated by desmoid tumor, and died at an age of 40. She was diagnosed at age, our patient was diagnosed at the age of 24 with multiple colonic polyps and gastroduodenal polyps with desmoid tumor and retinal pathology, and diagnosed as, what do you think? So, what would you do? So, MRI abdomen done in our hospital is showing the following. This is the lesion that we saw. It's actually been discussed with our radiologist. It's showing an intraluminal lesions causing intersusception-like. This is why it's giving a mass-like lesion. Initially, it was like between differential diagnosis. Are we dealing with a desmoid tumor that is encasing the duodenum, or talking about intraduodenal? After discussion with the radiologist, it seems to be an intraduodenal lesion. So almost the polyps that we're seeing are evident here. This is an axial cut of the same lesion we're talking about. And this is something in the posterior wall.
This in the arrow, can anyone?
This is different from the lesion that we showed initially.
Actually, we thought initially it is, the lesion is extraluminal, the one on the duodenum, but it is, by repeating, asking the radiology and reviewing CT scan MRI, it is intraluminal and causes some form of intersusception. Yes. And likely when we correlate with enteroscopy, this is a huge polyp that's causing obstruction, and likely she's having intermittent susception to explain her vomiting, pain, which was brought her actually to Dr. Osman and admitted because of that. Okay.
So this lesion has been discussed. This is soft tissue, appearing like a soft tissue, going with fibromatosis if you will go radiologically. So this is, I would say, extensive fibromatosis of the posterior abdominal wall and the pararenal space. And this is... No.
This is فوق الكلى كده.
Yeah.
Above the
Adrenal.
kidney.
So this is an adrenal adenoma on the right side as well.
The previous
Yeah,
one's a soft
this one is the
tissue.
desmoid. Yeah, this is the desmoid, and this one is the adrenal adenoma.
It is actually extra abdomen in the wall. It's not intra-abdominal desmoid. It is in the abdominal wall, the desmoid. It was not intra-abdominal with adrenal adenomas.
So MRI was reported as follows. Soft tissue lesion estimated to be 4.5 by 7 centimeter in size, occupying the third, fourth part of the duodenum, most likely representing a large polyp. Another polyp is seen within the jejunum, right adrenal and adenoma. Soft tissue lesion is seen at the right posterior pararenal space and involving the posterior wall of the abdomen, likely to present fibromatosis. This was biopsied outside before and was consistent with desmoid tumor. So endocrine team were involved, and adrenal adenoma workup was done. She had suppressed ACTH with high 24-hour urinary cortisol. Despite she didn't have the cushingoid appearance, she was rather losing weight. She has a negative leukocytoma workup, which is important in the surgical management of this lady. And she has a functional adrenal adenoma with cortisol secreting. Thyroid was, ultrasound thyroid was done, showed multiple nodules. FNA was done, colloid goiter, there was no malignancy, so they elected to follow up. So this is our diagnosis, Gardner syndrome. Brief about Gardner, so
we thought it's easy to diagnose with a history of the cancer, always in patient was very young and family history of colon cancer and possible colonic polyp. You have to investigate thoroughly, and she was actually investigated, offered treatment, but because of her father died of desmoid, she's afraid and rejecting till to come to this stage. She has multiple duodenal obstructing, causing obstructive symptom. Unfortunately, also study some of the small bowel by MRI. It is also extending. Also, the big ones was in the jejunum, but the remaining very few at ileum. When we entered terminal ileum, there was numerous also polyp. Colon is full of. It is easy to diagnose, but now she is refusing most of modality of treatment, and we don't have a lot of option with this huge desmoid tumor and the family history of father died of desmoid tumor. So now the management. How many? Actually, FAB we have a couple of families actually with FAB, but Gardner with desmoid, for me, it is maybe the second or third case. I don't know about Abid and your Dr. Khalid.
It's a good question. Can you ask the audience for that?
Audience,
many
Dr. Khalid for Gardner. How many you saw Gardner? FAB, okay, we have families, but Gardner. Desmoid. We have a couple of families, yes.
In this case, not we have for Gardner for the first time. In this case, you got to take her colon out. She refused also to take colon out.
Since she was offered the age of 24. She's 20 years beyond this and still refused.
This is really unfortunate. I didn't know who saw at that time when he told her that this
Osman, he knows the story.
will go to cancer 100% by this age anyhow. She's lucky until now she didn't
Osman,
develop
can you
cancer, by the way.
So I know her. She had full discussion. The problem that she had, her father had surgery for cancer when he was 34. Then he ended up with a complication. He died from a desmoid after the surgery. And because
6 years later.
6 years later, but because they told her her risk of developing desmoid and may die from it like her father is high, especially after the surgery, because it's increased risk of the desmoid tumor after the surgery itself. That's why she elected.
She's hair is cut anyway.
She elected not to do the surgery just to avoid the desmoid, because in her brain, that's the thing killed her father. It's not the colon cancer; it's the desmoid cancer.
If she's refusing and you bring some of the family and you try to convince them and you document these things, this is her life. This is her choice. But at least you document the whole things. The discussion is clear to her.
She was a little bit depressed, but when we go around and see her, she's competent. She's competent,
especially when she's psychiatric.
The psychiatric team were involved.
She involved.
You need the psychiatrist to make sure
she has
that
some
she
depression.
really can take decision by herself.
And the family around, and discussing with her. Abid?
Definitely, this is her life.
Abid?
I think the management for this case is very difficult. Even if she had agreed to be operated, to accept the surgical resection. Removing her colon is easy, but small bowel also polyp, maybe she needs a lot of extensive endoscopy. But what about the stomach? You will keep the stomach, or because it seemed to be she had an extensive polyp there, risk of dysplasia. There's no role now, or there's no clear management for those patients who have a gastric dysplasia. She need a gastrectomy or not. And back to the point of educated the people, I think this is normal because I have a similar patient, is a young 22, FAB, her family refusing colonoscopy. Refusing, despite we explain the full risk of cancer at age probably 20 or less than 20. So this I think is normal in our culture. Sometimes they know the diagnosis, they know it's a subsequent complication of the disease, but at the end they got their decision. So colon is easy, stomach very difficult. And she need to have a multiple endoscopy to remove her small polyps.
Fun that it make it, but now we have duodenum, jejunum.
No, there is no. This is fundal type, which is like hyperplastic. The one that is in the duodenum and this is the one. And what you go with something called Spiegelman or criteria, where you have the way it looks really at more of the there is a criteria which is Spiegelman. It's not in my mind now. It
We will
depends on the
review it
size,
now.
the number, the histology, as well as the
Displays, yeah.
grade or whatever is there.
No,
And
the
then
question-
each one has a certain point, and you calculate it. If it is a small one, the risk is really small, and then you just follow them up, and these type of small polyps there, you can take them out. If it is numerous or something, you may end it with surgery, even in the upper part. But and you may add a non-steroidal like Silindac or.
Abdullah did an excellent review, and he will take us to the. Yes.
I mean, the question now, if you will sit with the patient, and she's addressing clearly her first that she has the risk of desmoid. I mean, how would you convince her that she will die from the colorectal, for the CRC, the colorectal cancer, rather than the desmoid? I mean, this is the challenge. I mean, having the review, how common we have it, do we have enough literature to convince our patient that the risk of desmoid would be less than the colorectal cancer? So let me take you just in a brief review, during which I will give you as well follow-up of what happened to our patient. It has the same. Actually, this is why I'm giving this. They're using interchangeably FAB plus extracolonic manifestation is Gardner, and the opposite. So even attenuated FAB, they can present with extracolonic manifestation, and they would have Gardner as well. They would be called as Gardner. So this is a subset of FAB. They have the same risk of colorectal cancer as the literature review that we have. So FAB is the general term. We have attenuated FAB with less than 100 polyps being part of it, as well Gardner with the characteristic retinal finding being usually the part of the Gardner diagnosis. So these are the benign extraintestinal lesions associated with Gardner syndrome, include osteomas, cutaneous lesions, desmoid, which is considered as a benign but locally malignant, what's so-called locally malignant because it has tendency to have an invasion of local tissues. As well, the congenital hypertrophy of the retinal pigment epithelium and adrenal adenomas and nasal angiofibromas. The extracolonic malignancy, the most common is the duodenal and periambulary, which account for 3 to 5% patients, thyroid cancer, pancreatic cancer, gastric cancer, central nervous system cancer like enterocolitis, and hepatoblastomas as well, small bowel distal to the duodenum, and possibly adrenal carcinoma. So these are the features. This is the characteristic retinal finding. As well, they have dental abnormalities, they have thyroid nodules problems, they have epidermal cysts. So those changes are seen in the general population up to 30%, but they are more common in FAB. So finding them doesn't mean they have Gardner, but they tend to have lesions more than the general population. Just to skip this for sake of time, this is the approach I would recommend if you have a patient with FAB, how to do the gene testing algorithm for the patient and for the family members if you don't know the gene mutation. So I would have this figure with me while explaining to the patient the risk of death from colorectal cancer. Now she has her colon inside, and we know that by most of the patients, by age of 45, they will develop the colorectal cancer, and by almost age of 65 or plus, 100% of them will develop colorectal cancer. And this is less with HbA1c. With the general population, it's almost 5 to 6%. So to complete the story that was already been told, she was offered colectomy at age of 24 outside our hospital. She refused, afraid of having the same fate of her father, which is a desmoid tumor. So the cause of death in FAB patients. Prophylactic colectomy has been shown to decrease the incidence of colorectal cancer and thereby improve the lives of patients with FAB. And now, after the era of having colectomy, prophylactic colectomy in the appropriate age, duodenal cancer and desmoids are now the leading cause of death in those patients. So just brief about desmoid. So it's an aggressive fibromatosis, and desmos meaning tendon-like. It's a tumor of connective tissue. It's locally malignant. There is some reports of spontaneous regression. This is a good, pros to convince your patient that some patients might have developed, they might have spontaneous regression in 20% or more. And the risk factors, our patients have all of them. The family history, her father, and the surgery risk. And this is how would it look under the microscope. And this is like the usual categorization of desmoid, subcutaneous, abdominal wall, or intra-abdominal. The usual treatment for desmoid, you usually divide them into two groups, either intra-abdominal we make the surgery the last one because it will increase the risk. We usually start with conservative management in terms of non-steroidal, anti-estrogen, and traditional chemo. Then you go for surgery. But for subcutaneous and abdominal wall desmoids, then the surgery is the first line. So lifetime prevalence of desmoid in patients with FAB is only 20%. The peak incidence is at the age of 30. The risk is increased with family history, as we mentioned, a personal history of osteomas, and following abdominal surgery. This is a nice staging that I found for desmoid tumors. It was, they were measuring the mortality of intra-abdominal desmoid tumors in patients with FAB. It was a single center review. They included 154 patients. So if I would say our patient was not symptomatic actually from the desmoid. She was symptomatic from the duodenal problem. So she was asymptomatic and she was less than 10 centimeter. We don't know whether it is growing or not. We need to have a follow-up. So she's almost falling in stage 1 desmoid. Now, so this is the mortality expected of stage 1 and stage 4. If she's stage 4, I mean the 20 years mortality is reaching 50%, but for stage 1, it's almost only just 20% mortality. So this is a good figure. I will keep it with the other figure that we have to weigh risk and benefits. How would you manage this patient now? This is the question. How to address her duodenal polyps? How to address now she's refusing the colectomy. How would you address this? As been mentioned by Dr. Khalid already, we have like tools for assessment, which is the Spigelman score. So this is the just easy steps how to go. You need to calculate the number of points, use the number of points to determine the stage, then use the stage to determine the follow-up. And this is the Spigelman. So clearly, if we just go over our patient as an example, we have more than 20 number of polyps in the hair duodenum. We have more than even 2 centimeter polyps, so more than 10 millimeters. She has 3 points, this is a total of 6. She has tubulovillous adenoma, she has a total of 8 points. There was no dysplasia in the removed polyps from her duodenum, they were in the colon. So she falls in stage 3. They recommend follow-up, but she's having obstruction added. And this is why this is one of the drawbacks of Spigelman, that it doesn't account the symptomatics, if the patient is obstructing. So they recommend follow-up, but the patient is obstructing. You need to do something about it. Again, this is the follow-up of some case series and cohorts. They are old one of Spigelman, like patients with stage 4 in the largest cohort of 368 patients. They have, at initial examination, they had stage 4 Spigelman, and duodenal cancer was 4%. Alternatively, and recently, we had this nice cohort study that was published in 2014 June, which is addressing the progression and management of duodenal neoplasia in FAB patients. This was from Zane Cohen Center at Mount Sinai Hospital in Toronto. And they actually established a new classification system that is easier to remember and maybe more practical and applicable. So let's take again our patient as an example. So they go into 5 stages, 5 stages, stage 0, normal, then this is the management you would do. Our patient has more than 10 millimeter and they concentrate mainly on the size. So if the size is more than 10, and this is adenoma, like our patients, you consider endoscopic or surgical resection. And 5 is definitely adeno-CA, and you need to go for radical surgery. And they start the screening by age of 25. So they included 280 patients, 18 patients, since 1980, and it was prospective review, a cohort, from 1980 till 2012. The median age at diagnosis of stage 4 disease, like our patient, was 45 years. And the risk of stage 4 disease was almost the third. So third of FAB patients, they have stage 4 by this age, after 15 years of follow-up. And in multivariate analysis, 6 type of colorectal surgery, years since colorectal surgery was done and stage were significantly associated with the risk of progression to stage 4. 5 of those patients, which represent 2.3%, developed duodenal cancer at median age of 58. And 3 died. 1 is alive, 5 years post-op, and 1 lost follow-up and recently diagnosed with T4N1 duodenal cancer. So she was reviewed by our surgical team, back to our patients, who offered the patient the option of gastrojejunostomy as an option to relieve her obstruction with having these large number of polyps. But again, the patient refused. So what would you do next?
After the review,
she was given actually since the age of 24 Sulindac, the long-term follow-up. She was not adherent. It didn't prevent her from having
Yeah, this is what actually it was gastro, tumor board, surgeon, everybody was involved, our team, and she's refusing most of the modality. But now she's obstructed.
So how, would you leave him without doing anything?
But at least stenting and
So the study you just mentioned, Abdullah, I was involved in some years in the screening for these patients. So these patients, all of them, they were patients who had total colectomy, and they
yes.
come yearly for duodenoscopy. This doesn't apply for
our
our
patients, yeah.
patients, but just for patients who with FAB or with Gardner, that's when you remove their colon. This is not the end. Still, they were coming every year, and we will do for them gastroscopy. And actually, what we use is the duodenoscopy. So we could use,
Side view.
we could see the side view, and we could examine the whole duodenum and the ampulla
Ampulla as
for this. This doesn't apply. The screening
Yes.
Abdullah mentioned doesn't apply
For this patient.
for
Yeah, but because the challenge
for
of
our
this-
patient.
yeah,
Because,
yeah, sure.
but I think this is something sometimes we forget. For patients with FAB and for colon cancer, that we just remove the colon and forget about their duodenum. Maybe this is the message we want to give.
yeah, sure. And the other thing, on the other hand, actually her colon there, which is the leading cause of this, but second leading is duodenal. See, now at least she's symptomatic. So, Abid,
I think you have to, again, convince her to have like an
Surgery.
surgical
surgery.
removing her colon, and then you have to think about the surveillance. Because doing the surveillance while she had a colon,
So surveillance doesn't apply for this
patient, yes.
For
No
her
more
now,
surveillance.
she's having a huge duodenal or jejunum polyps, and she's obstructed.
She's symptomatic.
And the colonic severe dysplasia, I think her colon also, but this is her body and she's refusing, but at least to relieve her symptom. Jejunostomy?
Do endoscopic jejunostomy, but what I'm saying is even if you do jejunostomy endoscopically, always you consent the patient for that she may go surgery, because you cannot guarantee that when you do the jejunostomy, perforation will not happen or something, and then the patient is stuck with you and said, I told you I don't want surgery. This is the problems. I think if she's saying don't want surgery, and this is I think she's killing herself, and this is unusual really. But if you go for jejunostomy, endoscopic jejunostomy, you can do that. I mean, you bypass that obstruction completely by endoscope, whether using a colonoscope and bypass that area. And the same technique like the big tube, except you hold the
No, I didn't think so. Like a stenting small intestines, I didn't think it's like an applicable.
There was another question.
Difficult to have like a stent in a small intestine. First, you cannot difficult to access the area. Second things is a lot of complications, and to be adding more risk for the patient.
To conclude,
It's not, yes. Yes, Salim? Intussusception, yes. Prof. Jibril. For debulking our, yes. Yes, we saw you, the multiple, the lumen we cannot say, difficult to pass. I passed it, but it was this side, we're causing the
Double balloon
and
endoscopy.
obstruction.
Double balloon endoscopy, you can
Do
multiple
the
sessions. you can
debulking
remove it,
multiple
yes.
sessions. This is what we try.
yeah.
Yes.
So just to conclude,
we discussed her. And
She doesn't want surgery.
no, we have show him again the duodenal.
So what we did is that we explained for her the risk. We told her either you go for the surgery for jejunostomy immediately, or we'll do the procedures. There's still a chance you could perforate and you go for as an emergency. She thought about it. The family, all the family were there, and she agreed to go for periodontectomy. And if anything happened, she was already considered to be taken for surgery immediately. They will only deal with the duodenum, not for
The duodenum.
They only deal with the duodenum.
She's still refusing the surgery. Actually, if you saw us, if you show
this is
no
the
video, this is
No video, no
endoscopy.
video.
I did. Can you show the first endoscope for
The
the
endoscopy?
duodenum? It was a long session endoscopy, but we was able to show us the. Yes, this is the jejunum. Yes, this is jejunum. This is a huge one in the jejunum. It was also removed, and show us the early jejunum, the one causing the intussusception with the lumen. Yes, yes, here. This is the one. It is. Can you show us? Show the lumen there?
Yeah, this is. It's not coming.
It's not coming here, yes. So this is the only small lumen above. All this was circumferential. Almost whole lumen was with a huge polyp coalescing together, it causing this huge obstruction. Okay, so
So she
this what
underwent
happened.
debulking and
Debulking,
she
actually.
presented to the
went-
clinic last visit. She was gaining 4 kg. She's still having occasional vomiting. We did small bowel follow-through just to make sure that she's not obstructing. This is her small bowel follow-through.
Definitely huge, but
And there is no evidence of intestinal obstruction for the time being. And we are still following her as our patient, and the patient is still refusing.
So what's your plan, Osman?
So last time I saw her like maybe 4 or 5 weeks in the clinic. I wanted to take another look, maybe do another debulking. She want to delay it a little bit. She's still, she's eating well. She's not vomiting as before. So I'll see her, I think, in 4 week times from now. Huh? Yeah, she gained weight.
Okay.
She gained
her-
after the first
her life.
debulking.
She's enjoying.
She was in hospital. You cannot discharge. She was
So
electrolyte.
before we did the debulking, she was on TBN. She cannot eat
TBN,
anything. She was
cannot
eating
eat.
vomiting fluid. So we did the debulking. Now she's eating. She's still not eating a solid diet. She's still in semi-solid, but she's enjoying the life. For now, I don't know. I don't remember. Is it like 6 months or after debulking?
It
or?
was
July. It was
actually
July 2020.
Yeah, so it's almost 6 months after the debulking. So we did it in July, and they saw her 4 weeks. She's doing very well, and I'm seeing her in
Gain weight.
another 4 weeks. Histopathology, it was an adenoma, tuberculous adenoma. She have Gardner syndrome. She's no. No, there was no cancer.
لا, no adenoma.
No cancer.
No cancer.
No cancer in the polyps.
And no dysplasia, no dysplasia. So it's,
man, any use of Cilindac or something? So would it?
she was. No, large polyps. And
Well, there is some study where they sometimes regress a little bit, and I don't
or
know.
regress.
24 years old. She's now 40.
Unfortunately, I
I
think.
don't know when did she start on it, but when I met her, she was already.
Yeah, since the age of 24, so she's almost 16 years on steroids.
So we will come to second presentation. The first one, as I mentioned, easy to diagnose, difficult to manage. Actually, yes, well done, Adel Ilah, extensive review. And second one will be, we'll go to between GI and hepatology. We need also to nag and always to with our colleague here of hepatology. So it is difficult to diagnose, but easy to manage. So we'll go through it with Dr. Jaweed, is our hepatology fellow, and we will also be interactive and ask opinion.
Bismillah ar-Rahman ar-Rahim. I will present an unrecognized complication of a common disease, but difficult to diagnose but easy to treat. A 16-year-old female was referred to our hepatology outpatient clinic due to elevated liver enzymes, which were discovered incidentally during routine workup a year ago. She was frequently nauseated and complaining of abdominal distension with mild to moderate colicky on and off epigastric pain. There was no history of liver diseases, blood transfusions, herbal ingestion, or cholelithiasis. She was not an alcohol or drug consumer and was not taking any medication except insulin. In addition, she didn't show any symptoms and signs compatible with acute or chronic hepatitis. Past medical history showed she is known diabetic for the last 4 years, and she is taking insulin. The requirement is 1.2 units per kg per day, but with poor glycemic control, her last HbA1c was 11.5%. And this has been complicated by several episodes of diabetic ketoacidosis. She is also suffering from celiac disease. It was diagnosed 2 years ago based on serology and duodenal biopsy. She was compliant well to gluten-free diet. Family history was only her brother had type 1 diabetes and her younger brother had eczema. There is no history of liver disease or other autoimmune disorders in the family. Obstetrical history, she had menarche at the age of 12 years with irregular periods which last for 4 days and a normal flow over the last 2 years, and her last menstrual period was 3 months back. Her BMI, physical examination revealed her BMI 22.7 kg. She was not jaundiced. There were no stigmata of chronic liver disease. She had a non-tender distended abdomen with hepatomegaly, but there was no ascites. Pubertal development was normal. Remaining of the physical examination was otherwise unremarkable. Her labs analysis was compatible with major elevations in the liver enzymes. The ALT was 260 units per liter, AST 150, ALP 260, gamma GT 178. The synthetic functions were normal. Her triglyceride was a bit elevated. It was 5.2, and cholesterol was 7.2. Blood complete and ferritin were normal. These were the LFT pattern over the year 2014 with elevations and the AST reaching up to 3,500 units at times. And this is the tabulated form, the same.
Yes, the same.
So the AST was more elevated than the ALT, reaching up to 3,600 something. So what's your
and one of this high elevation 1,000 was, she was seen having this type of fluctuation of liver enzyme seen in hepatology, came to the admitted with all investigation done negative, admitted for liver biopsy, was in the ward. After biopsy, pain, and again after being in 200, 100,000 of enzyme, this fluctuation, and she is celiac patient, diabetes, and uncontrolled most of the time. So any thought from the juniors? Then we'll ask the senior. Autoimmune, she has about 1,000, but back to almost baseline, little bit high, without evidence of cirrhosis. Autoimmune, if you left untreated for almost 1.5 year with 1,000, they progress so fast within 6 months to cirrhosis. Nawaf. Celiac hepatopathy. It reached 1,000. It reaches very rare. So usually mild, modest elevation. Only abnormal. And during the time of liver biopsy, pain at that time. No herbal, no medication, nothing.
No.
No, at all. No. Even I saw her in the ward, she was fine. Post-liver biopsy, the pulse started. She was mild pain, but never went to hypotension significant.
Biopsy, virology for the liver.
Sorry, bro?
Viral screen for
Viral, it was...
so viral hepatitis is one of the differential. Celiac disease, autoimmune hepatitis.
All negative. All negative.
We did this, so we'll proceed. Actually, it was a dilemma and a challenge case. This all came to our mind. We sort of all these drugs, viral, ischemia, but yes,
But for the autoimmune, she did.
Hepatopathy.
about celiac complications. Probably they have like a thrombosis or like gut failure or anything. Or
Yes.
other liver disease. Probably the worst.
Mm.
She's 16 years old and they have to think about
NASH is a possibility.
But I
She was
think
not on any medications. In these enzymes were fluctuating, and she is uncontrolled diabetic with frequent admissions to the ER with diabetic
Yeah.
ketoacidosis.
When she had this attack, have ever been she's hypotensive or
No,
I mean never she get like ischemic hepatitis and then back?
no.
no.
Okay. NASH is a possibility.
NASH is a possibility, but in
But
thousands.
also Nash was ALT 1000, 4000.
Have one patient.
No, but it will not present with.
Passing stone sometimes giving you like
Prophet Jibreel, give 1000, 4000.
These are the issue, the enzymes.
AST in the thousands, there are probably few differential diagnoses. I agree with Abid. I think autoimmune is a possibility. Diabetic with celiac disease. A complication of celiac, I don't think this is with the thousands range. So it's either medication, viral hepatitis, or autoimmune. These are probably the only possibilities.
But
Sometimes, if the patient has pain, intermittent pain, sometimes CBD stone, they could present within few hours of very high liver enzymes, but that depends really on
February 26th is also 1300, 27, 16, 28 coming back to normal, twins almost normal, then October 15 just suddenly 3000. After 2 days, it goes back again. So
This is
2000 and
This is you see it.
1 day, 2, then it goes back.
This is you see it mainly in passing stone. Usually we see like this pictures really in passing stone. When a patient is passing stone,
But the bilirubin was consistently
regardless, yes, we can see
normal.
like this.
The alkaline phosphatase gamma GT.
Yeah, we have like this sometimes.
It
Ultrasound.
will go. Yeah. So this was our differential,
Yes,
like
Dr. Abid.
celiac, autoimmune.
Maybe.
Maybe.
يلا فاتح دكتور فاتح.
Okay, so
Yeah.
we'll proceed with it.
We'll proceed for investigation.
So serology for hepatitis A, B, C, hepatitis E, ABV, and cytomegalovirus virus were negative. Other causes of immune and metabolic hepatic disease were excluded is serum ceruloplasmin, copper, alpha antitrypsin, alpha fetoprotein protein was normal. Immunoglobulin A, G, and M level were normal. ANA, ASMA, and AMA, and liver kidney microsomal antibodies were normal.
Ultrasound.
Sorry?
No, go ahead.
Celiac serology was positive. The thyroid function test, the follicle stimulating hormone, LSH, and prolactin were normal. Her vitamin D level was slightly low. Vitamin B12 and folate were, vitamin B12 was unremarkable, folate slightly high. Ultrasound and CT scan of the abdomen showed liver enlargement, 23 centimeter span with bright, coarse ecotextures without evidence of splenomegaly or ascites. So what will you do
fatty
next?
liver. Fatty liver 2000 يا شباب. I never heard.
Can't come to this, but the one that surprised me is the rapid
Rise.
decline.
Yes.
This is the problems. Usually the fatty liver, yes, they can go up, but they come down slow with the patient lost weight.
Or drugs or
Delhi can give you like this. I
Yes.
mean the.
no. We check even when she was in the ward. We check and marcipan and biopsy. This is what she's actually non-compliant. And
I mean, lymphoma is one of the complications of celiac disease.
usually lymphoma will go with infiltrative processes like cholestatic intrahepatic cholestasis rather than by thousand. But celiac hepatopathy, we sort of about it. It could be really raise the enzyme, but Dr. Jaweed will give us.
Yeah, this is the liver biopsy. Actual, this is the patient's liver biopsy. So anybody. So the hepatocytes are swollen, and there is no cellular infiltrate like plasma cells or lymphocytes, and so any.
So any stain, anything, what could be?
So we did the staining. This is a PS stain.
PS stain. Huh?
Alpha-1 antitrypsin.
I cannot hear. Huh? Alpha-1 antitrypsin.
No, it was normal.
What else? Amyloidosis. Okay.
So
Dr. Jaweed.
this was the liver shows the presence of abundant glycogen in the cytoplasm of the hepatocytes. The PA stain is strongly positive. This deaminase PAS deaminase is diastase is negative. Pulse stain which is done for hemochromatosis is no iron depositions. There are no features of hepatitis or septal fibrosis. And the duodenal biopsy showed duodenal mucosa with total villus atrophy, increased intraepithelial lymphocytes, and crypt hyperplasia consistent with celiac disease.
So it could be celiac hepatopathy?
So what's now your...
What do you think? Glycogen?
So glycogen storage disease, the patient will present, from the childhood and the organ involvement, various organ involvement.
Hepatomegaly and fluctuating by 1,000. Yeah. Okay, so...
So this is the diagnosis is glycogen hepatopathy. So despite of our efforts with the help of multidisciplinary team composed of hepatologists, diabetic educator, dietitian and endocrinologist, we have encountered difficulties to control patient's diabetes while she persistently remains symptomatic due to hepatomegaly. We assume that it was due to the patient's non-compliance is common in this age group. So a few words about the glycogen hepatopathy. In 1930, Moriek was the one who described Moriek syndrome. It is a rare complication in children with poorly controlled diabetics of type 1. This syndrome is characterized by overloading of hepatocytes with glycogen, hepatomegaly, and abnormal liver enzymes associated with growth failure, delayed puberty, and Cushingite features. But glycogen hepatopathy, it's now become known that the hepatic defect alone can occur without other features of Moriek syndrome. So then the new term it's called glycogen hepatopathy in children, adolescents, and young adults with long-standing poorly controlled diabetes, and it has recently been reported in patients with type 2 diabetes as well, those who are taking insulin. So this is the this is the pathogenesis. The actual thing is this hyperglycemia, there is diffusion of the glucose into the hepatocytes and is converted to G6PD. This the insulin whenever given to the patient is caused dephosphorylation through the phosphoprotein phosphatase. So this causes two things. One, it activates the glycogen phosphate, so there is no glycogenolysis. So, and on the other hand, it causes the glycogen synthase enzyme from inactive to active form, which converts the glucose into glycogen. So there is accumulation of the glycogen. Several studies have shown that intensive glycemic control or normalization of the glucose metabolism in post-pancreatic transplantation leads to normalization of the liver enzymes and resolve hepatomegaly as well. Is complete resolution of the histopathology as early as the adequate control of glucose level reached 3 to 4 weeks with favorable prognosis. It has also been shown recently that improved glycemic control after treatment with continuous subcutaneous insulin infusion resulted in complete resolution of the glycogenic hepatopathy. So clinically, it is important to distinguish this entity from NAFLD, as the prognosis, pathophysiology, and treatment all are different. NAFLD cannot be excluded by history, physical examination, or ultrasounds. So, and one important thing is glycogenic hepatopathy may relapse many times. So this is the main, not going into the details, but the main differences between the NAFLD, glycogen hepatopathy, and celiac disease. Symptoms-wise, the NAFLD patients will be asymptomatic, while the glycogenic hepatopathy might present with epigastric pain, and the celiac depends upon the disease severity, might be asymptomatic, mild symptoms. They show malaise and fatigue or symptoms of severe liver failure. The signs, the main signs in the glycogen hepatopathy is hepatomegaly. It might be tender or non-tender, but in the NAFLD, it's non-tender hepatomegaly. And the celiac disease, maybe this normal physical examination to liver failure signs with encephalopathy in CLD stigmata. What is the difference between these and regarding the liver function tests? In the NAFLD, mild to moderate, persistent elevated liver enzymes. This is the important thing, persistent elevated liver enzymes. While in this glycogenic hepatopathy, severe flares of transaminase reaching up to 4,000, and mild to moderate elevation of the gamma GT alkaline phosphatase. The liver synthetic functions are normal, the lipid profile may be deranged. While in the celiac disease, it depends upon the severity of the celiac disease. Radiological, it's not useful. In the NAFLD, the ultrasound is not useful. The CT scan is useful to reduce hepatic CT attenuation due to fat deposition in the liver. While in the glycogen hepatopathy, this is a CT scan showing increased hepatic attenuation due to glycogen. The other one is the fat. So, in the celiac, it depends upon, again, the celiac disease severity. Maybe there are other features of the celiac: dilated small bowel loops, enlarged mesenteric lymph nodes, non-occlusive intussusception, increased peristalsis, abnormal jejunum folds, and mesenteric lymph nodes. But the most important difference is by the histopathology for definitive diagnosis. In the NAFLD, there is maybe steatosis alone, only the fat, the cells, and the NASH causing inflammation of the hepatocytes, or and there is risk of progression to cirrhosis, and even in some cases hepatocellular carcinoma. While in I already mentioned the glycogen hepatopathy, swollen hepatocytes, pale cytoplasm, abundant cytoplasmic glycogen, and this PS is positive and the diastase will be negative. So there is no necrosis, no evidence of necrosis or inflammation, steatosis, and it will not progress to fibrosis. The celiac, the same like NAFLD. Sometimes the biopsy is non-specific, but usually it's the cellular infiltrate, the plasma cells and the lymphocytes. It may be showing Kupffer cells, hyperplasia of the Kupffer cells, steatosis, and the association of other diseases along with the celiac. The pathogenesis, as you all know, and there is lipid accumulation in the NAFLD is a result of chronic hyperinsulinemia and hepatocellular insulin resistance. In the glycogen hepatopathies, the mechanism is, I told you, because of the hyperglycemia and the enzymes involved in the metabolism. The treatment for NAFLD, again, the usual steps: weight reductions, control of diabetes mellitus, and regarding the treatment of glycogen hepatopathy, strict control of the diabetes, so it's a reversible disease. And the treatment of celiac disease, it can progress to fibrosis and cirrhosis, but it carries a good prognosis because it's reversible with strict gluten-free diet. It will take 6 months to 1 year for complete resolution of the pathology. The reversibility considered is a pathognomonic to celiac hepatitis. So what's the aim of this presentation? This glycogen hepatopathy remains an unrecognized complication of type 1 diabetes, characterized by severe transaminase flares, hepatomegaly, and reversible with adequate glycemic control. For that, we suggest that clinician monitor the clinical response to optimal glycemic control. Clinician awareness of the glycogen hepatopathy should prevent diagnostic delay and has implication on the management of the end outcome of the patients. And we are thankful to Dr. Waleed Hammoudi, and we are going to publish this case because this is the first case from Saudi Arabia, the glycogen hepatopathy combined with celiac disease. There is one case reported from King Fahd Hospital from Jeddah, but it was only the glycogen hepatopathy not associated with celiac disease.
And actually, this table comparison between the three forms, celiac hepatopathy, glycogen, or NAFLD, was among the paper will be published by Dr. Waleed Al-Hammoudi. So, and only, as I mentioned, difficult to diagnose this Marek syndrome, which is a flare with the patient with diabetes, poor control. It's typical with typical histology, but easy to treat. But she is same. She's another difficult patient. The other one difficult convincing her, and this also, in spite being a dietitian, we went to her, and she was symptomatic during the attack. When at least we document this attack during her admission post biopsy, really tender hepatomegaly in pain, flare 1000, and we explain, but I think last time seen still celiac serology positive, and prognosis, as I mentioned, it doesn't progress actually, not like the NAFLD progress, cirrhotic, even hepatocellular carcinoma risk, but here glycemic control, it is reversible, totally reverse the glycogen hepatopathy. But still, it will be there, but will not progress.
The tight glycemic control is the only...
Glycemic control, and here I think celiac also adding, so we need to control all the other confounder and...
No, the glycogen hepatopathy is it typical like the enzyme will reverse or back within like a week?
Yes, flare.
Within
few days.
They back again normal within days?
This was the hallmark of this challenging to us. Why she immediately symptomatic tender hepatomegaly? It was normal, then 1000, then back, and we reviewed chart the same pattern, and then this glycogen deposition in the liver. Then we searched for that. And this came to, so it was typical, but actually. I think 4 reported case, but this is the first with celiac.
So in the textbook, they back again within days?
Oh, yes.
Interesting. That's very interesting.
Last year, I reported a case report in gastroenterology. In gastroenterology.
This.
Okay.
Yeah. So it was also, it is a hepatology case, but I think our touch was there, and I hope, would like to thank everybody. Any question before we conclude for the dinner? Thank you.